Good morning, everyone. I'm Alessandro de Maio, a medical student in his final year at La Sapienza, University of Rome, and today we'll present you a study that we've been working on for the past year and a half, and thank you so much for watching me. Magnetic resonance guided focused ultrasound versus external radiation therapy for the treatment of pain in bone metastases, a multi-center open-label phase 2 clinical trial. It is currently estimated that 330,000 patients in the US alone are diagnosed with a metastatic bone disease. Of these, 64 will experience pain and typically be exposed to a variety of skeletal-related events, often requiring radiation therapy, as part of a typical pain palliation treatment line, together with supportive medication as well as surgery. Focused ultrasound instead has an emerging role in this field, and it is approved in the US, Europe, Asia, and Canada, and it is able to provide pain palliation via periosseal denervation. Our main objective was to compare external beam radiation therapy, the standard of care, versus magnetic resonance guided focused ultrasound, with typical improvement times of 1 to 3 days after one session delivering ultrasound energy. While for the radiation therapy, typically from the literature, we know that improvement time is typically 1 to 4 weeks after 1 to 4 sessions delivering radiation energy. Test measurements used were the VAS, BPI, as well as the C15 palliative care and the bone metastasis 22 for specific subcategorical analysis. A multi-center open-label phase 2 clinical trial was then designed for a 12-month follow-up. Inclusion criteria were patients age greater than 18, a VAS greater than 4, and a treatment area smaller than 100 square centimeters, together with no previous local radiation therapy. Exclusion criteria instead were a life expectancy shorter than 3 months, a poor performance status, and typical contraindication to a magnetic resonance guided procedure. Study outcomes were primarily improvement and secondarily complete remission and partial remission, quality of life, as well as overall survival. 229 patients were assessed for eligibility criteria, 198 underwent treatment assignment, respectively 100 for the focused ultrasound group with 38 who completed the follow-up program, and 98 patients who underwent radiation therapy with 23 who completed the follow-up program. No differences were found at the baseline characteristics, both for sex and the treatment area, as well as the 4 tests provided for pain assessment. Having a look at pain improvement, here in blue, we can see the focused ultrasound group, and in red, the radiation therapy group. And we can see that focused ultrasound group confers a significant advantage already at the first month, and this was kept throughout. While for the radiation therapy group, the patients improved around the 6th month, but then relapsed. A hazard ratio was found for 2.23 in favor of magnetic resonance guided focused ultrasound, and similar findings also for the BPI were found, but the BM22 and C15 were used for subcategorical analysis. Here on the left, we can see, in fact, a confirmation of the previous findings with greater proportions of patients and resulting in complete remission. While here on the right, we can see typical radiation-related side effects like physical dysfunction, dyspnea, changes in appetite, nausea and vomiting, and their impact on quality of life, as having also statistically significant differences. A Kaplan-Meier survival curve was then also followed, and for a hazard ratio found of 1.38 in favor of magnetic resonance guided focused ultrasound, with an overall time of mean survival of 7 months out of 12 in the focused ultrasound group and 5.2 months out of 12 in the radiation therapy group. All in all, as we know already from the literature, magnetic resonance guided focused ultrasound is a safe, efficient, and cost-effective alternative. But with all the limitations of our study, we could say that it also confers significant advantages in terms of pain remission, no association with radiation-related side effects, as well as association with quality of life, as well as prolonged survival. So where do we go from here? A randomized phase 3 clinical trial is surely needed, as well as can we go beyond pain palliation in these patients? As also some studies already pointed out some tumor control, but no pathophysiological explanation is still available. And in the end, routine application of focused ultrasound technology, we believe it is the future, and the future is really now. Thank you so much for having me. I want to thank my family, my professor, Alessandro Napoli, and all the residents in the radiology department who followed me. Thank you.